Massachusetts General Hospital. He's the Benjamin Councilman, Distinguished Professor of Pathology at Harvard Medical School, and Pathologist and Chief Emeritus at MGH in Boston. He's a long-standing interest in mechanisms of graft rejection and acceptance and the pathological analysis of bone biopsy. His research has been continually funded by the NIH since 1976. What an achievement. He's trained over 60 fellows. So it's with great pleasure I introduce Dr. Colvin to talk about, is there evidence for a causative role of DSA in solid organ transplant rejection?
Thanks, Trish, and good morning, everyone. I was assigned, could we see the first slide? I was assigned this topic, is there evidence for a causal role of DSA in solid organ transplantation by the organizers of this meeting. And I think the origin of this topic was an internet debate that I believe Fadi Laka started in the spring and elicited a lot of comments from dozens of people on both sides of the question. And I don't know why I was assigned to do this, but I took it on. This will be a little different sort of talk. I've decided to do this in the form of a debate, and I take my cue from Galileo, who was very reluctant to propose his own theories for fear he'd have to go to the Inquisition, because Copernicus had been disallowed by the Catholic Church a few years before that. So what he did, he published a debate in which the two theories of the universe were debated between Salviati and Simplicico and moderated by Segredo. And he did this in a way that he could deny he was agreeing with either of them. So what I've done is I've changed the title to a dialogue concerning the two chief immunological theories of graft rejection and a debate between the antibody-centric and the T-cell-centric theories. Now, I realize this group is clearly on one side of that issue, and if we had to say there's no antibody-mediated rejection, we could just close the meeting now. So I realize there's a little bit of a point of view in this group, and mine too, but we're going to have this argued on both sides, first by the antibody believer, AB, who I call Abel, and the antibody denier, AD, Adam. And it'll be moderated by open line, OM, Omar. Well, there they are. I won't name anybody. So Omar starts off by saying, I would like this debate to consider the following topics: the specificity of the biopsy findings, the contributor of T cells, evidence from complement studies, response to therapy, causal evidence, Koch's postulates, and other causes of graft failure. We'll proceed in that order, says Omar. You can begin with an opening statement. So Adam says, the term antibody-mediated rejection should be used with caution until scientific causation is established. Mislabeling could misguide scientific investigations and trigger unwarranted interventions. Abel responds, if we avoid diagnosing antibody-mediated rejection, we will inhibit scientific investigation, discovery of an effective therapy, and endanger patients. Mislabeling should be minimized by improved diagnostic techniques and knowledge. Okay, let's see if we can close that gap. For my opening statement, I compiled a list of publications of these subjects for your comments. And interestingly, this is the last 50 years. And as you can see, hyperacute rejection started it off, followed by the discovery of T cells as a separate tribe in the immune system. HLA class 1 antibody-mediated rejection was defined histologically and immunologically by Holleran's group. C4D was added by Helmut Fuchs. We added chronic antibody-mediated rejection sometime later. Single antigen beads came along, and then as you can see, the number of antibody related papers rose considerably. Abel, as As you can see, AMR publications far outnumber the TCMR publications in the last 10 years. Oh yes, but that shows AMR is a fad. TCMR publications are increasing recently, while AMR publications are not. Well, perhaps they are converging and the gap is closing. Our first topic is the specificity of the biopsy findings of AMR. Adam says, the fundamental problem regarding specificity is that we would never make a diagnosis of TCMR without lymphocytes, T cells if we use anti-CD3, in the graft. Yet we are happy to make a diagnosis of antibody-mediated rejection without ever seeing antibodies either in the kidney or in the circulation. Abel, several studies have shown HLA antibodies can be eluted from rejected kidneys, rejected graft nephrectomies, or biopsies in patients without detectable circulating antibody. And there are well-documented diseases mediated by antibodies in which the antibodies are not seen in the target, such as Graves' disease, myasthenia gravis, ANCA disease, and hyperacute rejection, which you acknowledge, Adam, is mediated by antibodies. Omar, the lack of detectable immunoglobulin is probably because the antibodies do not precipitate as an immune complex. In contrast, C4D forms a covalent bond with the target tissue. As an aside, Adam, T cells in the graft are not specific for the diagnosis of T cell mediated rejection either. Adam continues, in a study of heart transplant biopsies by Rodriguez, even when antibody was detected by immunofluorescence, it was associated with dysfunction in only fewer than 5% of the cases. You are correct, immunoglobulin staining was found in about 66% of patients, but only 3% had graft dysfunction. However, the immunoglobulin was often in a perimyocyte pattern, probably not binding to antigen, but due to edema. Notably, in the Rodriguez study, graft dysfunction did occur in 25% of the patients with C4D and C3D deposition, which was typically in a capillary endothelial pattern. Furthermore, 40% later developed chronic vascular rejection. Omar, so in heart allografts, microvascular complement deposition is more specific for AMR and graft injury than interstitial immunoglobulin. The same is true in liver grafts and probably other grafts.
Sure. Yeah.
Adam, the histologic criteria used to infer the presence of antibodies, including C4D, microvascular inflammation, and transplant glomerulopathy, are not specific. You're right, you're partly right. The histologic criteria of microvascular inflammation and transplant glomerulopathy are not specific, but they are strongly correlated with DSA. In contrast, linear C4D and peritubular capillaries is specific, seen only in allografts, not native kidneys, and more than 50% of them have detectable circulating antibody, depending on the techniques and criteria used. One strength of the C4D staining is that it is independent of the nature of the antigen. Similar, says Omar, similar associations between donor-specific antibodies and HLA, and between donor-specific HLA antibodies and the lesions characteristic of antibody-mediated rejection in the kidney have been seen in other organs, lung, liver, heart, pancreas, composite tissue allografts. This coherence supports a common mechanism, namely AMR. Okay, let's go on to consider T cells. Abel. Adam. Abel, you shouldn't disregard the contribution of T cells. We all know that T cells, primarily T follicular helper cells, are necessary for triggering B cells to produce antibody and differentiate into plasma cells. Furthermore, TCMR is a risk factor for later AMR, as shown by several groups. Indeed, mixed reaction, TCMR and AMR, occur together in about 70% of the biopsies with AMR due to de novo AMR. Adam, I have no doubt that TCMR and AMR are synergistic, as you've described. We know that in addition to T follicular helper cells in lymph nodes, T cells in the graft produce cytokines such as interferon that activate macrophages and increase the expression of MHC antigens. Many studies have shown, such as the early studies of McGill, that a component of AMR drastically and adversely affects the outcome. This supports the dominant importance of AMR in the effector phase of rejection. It would be misguided to place too much emphasis on humoral mechanisms of rejection to the point where cellular mechanisms are neglected. The most common form of antibody-mediated rejection is late mixed rejection, which also has the worst prognosis, with median allograft survival of about 2 years. In these cases, it is unknown whether the humoral or the cellular component conveys the greatest risk. Omar responds, agreed. Much work is needed in this area, including the development of more effective agents that selectively target the underlying biology. The field is in great need of new therapies for cellular rejection that are based on known mechanisms, and these therapies should be associated with reduced risks. We also need better therapy for antibody-mediated rejection. Omar, if DSA are relevant, complement deposition or activation should be correlated with outcome in pathology. Let's examine the evidence from the complement studies. Abel, studies beginning with the first description of C4D staining by Fuchs showed a worse outcome with C4D deposition in peritubular capillaries. One of my favorites is that from Alex McGill's group, looking at TCMR plus or minus C4D. And you can see the data there, that in the presence of T-cell mediated rejection, C4D has a significant worse outcome. Other studies have shown a correlation between C4D deposition in allografts and progression of graft injury. For example, a study from the DCAF studies and a study of transplant glomerulopathy. In both cases, the presence of C4D was associated with a worse outcome than those that had DSA without C4D. Although not all studies show such an effect, a comprehensive meta-analysis with over 3,000 biopsies, indication and surveillance biopsies, concluded that the presence of C4D was associated with inferior allograft survival compared with DSA or histopathology alone. Adam, but C4D can be activated by the lectin pathway, independent of antibodies and C1q. Therefore, C4D cannot be taken as evidence of DSA activation of the classic pathway. Well, you are right. However, essential lectin pathway components, MASP1 and MASP2, were detected in only 3% of the biopsies with C4D deposition in 2 early studies. To my knowledge, this hasn't been pursued further with good reason. Omar, the lectin pathway may still be a factor since it can promote rejection synergistically by binding to carbohydrates or non-complement fixing antibodies, as shown by Baldwin's group. So we shouldn't rule out a contribution. Many studies have shown a correlation between the ability of DSA to fix complement in vitro and the progression of graft injury. These were compiled in a meta-analysis and among 18 peer-reviewed publications, including over 1,000 biopsies. 38% of them had complement-fixing antibodies. The overall hazard ratio of graft loss with complement-fixing DSA was 2.94, compared with DSA that didn't fix complement. Here's an example of the association of C4D fixation with poor outcome from the Paris group of Lupe. Adam, C4D deposition clearly doesn't indicate acute rejection by itself. ABO grafts commonly have C4D without other evidence of rejection, such as microvascular inflammation or graft dysfunction, and have excellent long-term survival. Abel agrees. Banff classifies these as C4D without evidence of active rejection. The presence of C4D does indicate that there are anti-endothelial antibodies that fix complement. Why this fails to elicit endothelial injury is a mystery that begs to be solved. Omar, yes, if we knew the mechanisms of accommodation, we might be able to induce it intentionally. In HLA disparate grafts, where the phase of so-called accommodation usually progresses to chronic antibody-mediated rejection. Adam, on the other hand, a substantial fraction, up to 2/3 of reported cases of AMR are C4D negative. This surely argues against the diagnosis of AMR. Abel, not all DSAs can potentially mediate endothelial not at all. DSA can potentially mediate endothelial injury through at least 5 known pathways. A direct effect, as shown by Elaine Reed, complement activation, and FC receptors on circulating leukocytes. Not all antibodies fix complement. The ability to fix C1 complement in vitro by DSA is strongly correlated with C4D deposition in vivo, as shown by Lupia's group and others. Only pathway number 2 would be expected to have C4D. Omar, is there evidence for AMR in the response to therapy? Oh, can I go back? Yeah. Adam, antibody targeting therapies do not reverse AMR, and in anecdotal cases in which improvement was observed, the effect of therapy on non-humoral immunity could not be excluded. Abel, I disagree with your first point. More than 2/3 of patients with active antibody-mediated rejection after kidney transplantation have had a response to antibody-targeted treatment, leading to allograft survival. However, you are correct that these measures affect non-humoral mechanisms. Proof requires a means to selectively remove antibody or inhibit its production. Perhaps the closest to this is the use of the streptococcal endopeptidase that rapidly cleaves IgG, known as IDUS. Pre-transplant treatment with this drug prevented early MR in highly sensitized patients, as reported by Montgomery. Also, plasma protein A selective removal of IgG by immunoabsorption in Bowman's group also inhibited antibody-mediated rejection in pre-sensitized patients. Abel, how do you explain that complement inhibition does not affect the progression of transplant glomerulopathy or capillaritis, as shown by these studies, which I believe rule out a role for complement? The first study from the Mayo, C5 complement inhibitor does not prevent subsequent transplant glomerulopathy. And another study with the C1s inhibitor does not affect capillaritis in antibody-mediated rejection. I agree that these studies argue strongly against a complement participation in these 2 lesions of antibody-mediated rejection, transplant glomerulopathy and microvascular inflammation. But they do not argue against a causal role of DSA. Observations in humans support an ADCC mechanism in camera, such as the high levels of NK transcripts reported by Holler's group, and the association of microvascular inflammation in camera with the genetic variant of the high-affinity NK IgG receptor. This receptor variant did not affect complement fixation or C4D deposition. Omar, so we need to consider that antibody can mediate injury by 3 proved pathways and perhaps other unknown mechanisms. Therapy will be needed to be directed at the relevant pathway, either a direct effect on the endothelium, complement fixation, or ADCC. Omar, okay, how about AMR in the absence of DSA? What accounts for the reports of DSA negative C4D positive AMR cases? Abel, presumably titers are too low to be detected by current techniques. One study has shown that some of these DSA negative patients have donor HLA specific B cells in the circulation. There's also the likelihood that some are due to non-HLA antibodies, and we're going to learn more about this, I think, in the future. This would account for the rare cases of AMR reported in HLA genetically identical sibling allogroups. This seems like a big problem to me. A recent paper by Senef and others showed 60% of patients whose biopsy met the Banff 2017 criteria for AMR had no detectable DSA to HLA. Here are their data. And on the right side, the DSA negative, they had about 60% of their cases with this. There was a correlation with C4D and with previous transplant in this group. And the ones with DSA had a significantly worse outcome than the ones that had the histologic criteria of antibody-mediated rejection, but without detectable circulating DSA. This study shows that DSAs are associated with graft loss. It is notable that DSA-positive recipients more frequently were retransplants or SC4D deposition. The negative DSA results may be due to a high threshold chosen for positivity, absorption by the graft, or non-HLA antigens. Most other studies have shown a much higher frequency of DSA in AMR. Whatever the reason, the authors conclude that, quote, biopsies with AMR without detectable HLA DSA represent a distinct, often transient, phenotype with superior allograft survival. So these should be distinguished from the DSA positive group and perhaps treated less aggressively. Omar, so far we've talked about associations. What evidence is there for a causal relationship between antibodies and graft rejection? Adam, aside from the rare cases of hyperacute or accelerated rejection in HLA-sensitized patients, a causal relationship between antibodies and rejection has not been established. Complement-dependent cross-matching that avoids cytotoxic donor-specific anti-HLA antibodies has dramatically reduced the occurrence of acute antibody-mediated rejection and nearly eliminated hyperacute rejection. The pathology of hyperacute and accelerated rejection in HLA-sensitized patients is quite similar to that of acute AMR in other settings, for example, in a non-compliant recipient. So if you accept the former as proof of causation, don't you have to accept the latter? Adam, similarity does not prove identity. We need mechanistic studies. Omar, proof of causation is difficult in observational studies in patients. What about experimental animal studies? Mechanistic experiments in animals have shown that clearly that adoptively transferred DSA can indeed mediate antibody-mediated rejection, and they do so via complement-independent, NK-dependent ADCC. This can occur in recipients that lack adaptive immunity, T cells and B cells, and so these are not needed in the effector phase, but of course are necessary to produce the DSA in the first place. Here's an example of camera and mouse hearts caused by adoptive transfer of DSA in DRAG1 knockout recipients in a heart transplant with very severe chronic allograft vasculopathy. The problem with experiments in animals is that they do not mimic the full spectrum of human allograft pathology. Adam, good point. However, in studies of non-human primates show that the identical lesions of camera in humans associated with DSA, C4D, and elevated endothelial and NK transference occur in the non-human primate. This occurs in the absence of drug toxicity, donor disease, infection, or recurrent disease. As shown by Smith and colleagues, this begins with the production of DSA and progresses to C4D, microvascular inflammation, and chronic glomerulopathy. The observed temporal sequence supports a pathogenetic role of DSA. The same sequence has been confirmed in humans with chronic antibody-mediated rejection by Wiebe and others. The appearance of new onset donor-specific and HLA antibodies precedes acute and chronic antibody-mediated rejection. Adam. Okay, Mr. Smarty Pants, can you fulfill Robert Koch's postulates for causation in AMR? Just to remind you, Koch's four postulates in 1890 for proof that a particular bacteria causes the disease are these. First, the bacteria must be present in every case of the disease. The bacteria must be isolated from the host with the disease and grown in pure culture. The specific disease must be reproduced when a pure culture of the bacteria is inoculated into a healthy, susceptible host. And finally, the bacteria must be recovered from the experimentally infected host. Abel, I will try. Let Koch's bacteria be DSA and let the disease be antibody-mediated rejection. First, DSA must be present in every case of AMR. Up to about 90% of patients with AMR have detectable DSA in the circulation for the graft. DSA must be isolated from the host with AMR and its specificity determined. DSA have been eluded from rejecting allografts and their donor specificity confirmed. AMR must be reproduced when pure DSA is inoculated into a healthy, susceptible host. As I mentioned before, mice given pure DSA and lacking other elements of the adaptive immune system develop classic lesions of AMR, noted in patients. DSA must be recoverable from the experimental host. DSA has been recovered in the circulation of mice given DSA and C4D deposition in the allograft. Omar, jawohl, I think Professor Koch might be satisfied. What about other causes of graft failure? Abel, you said that about 50% of latent graft dysfunction is related to DSA. That indicates there are probably many other causes. Don't you think these are important? Of course. In fact, multiple causes of graft injury can concurrently or sequentially affect the graft. The challenge is that a significant proportion of our patients present at some point with more than one disease process going on in the graft. Agnes Fogo has likened the transplant biopsy to an archaeological dig with many layers of artifacts from past civilizations. We need to distinguish the mechanisms that are active at the time, such as microvascular inflammation or C4D, as evidence of ongoing activity of antibody-mediated rejection, and choose the appropriate therapy. Omar, the 10-year biopsy study from the Mayo Group supports the concept that non-immunological injury begins to become more prevalent 5 to 10 years after transplantation, and likely contributes to graft loss, or is even the primary cause of graft loss. These include CNI toxicity, hypertension, diabetes, and just the normal aging of the kidney. Omar, so let's have your final comments. Adam? Abel, you have argued well that there are DSA negative AMR and C4D negative AMR, and that microvascular inflammation is nonspecific. But that is way too confusing and too lax for my taste. Where is Copernicus when we need him? Adam, valid point. We need techniques to diagnose AMR. Intergraft transcript analysis is one of the new methods which improves the specificity of AMR diagnosis by detection of endothelial and NK transcripts, as shown through the pioneering studies of Haller and colleagues. Recent studies have also suggested transcript changes can predict chronic AMR in biopsies with C4D and no rejection, and predict response to eculizumab. Exciting. When can I expect transcript analysis in my pathology lab? Good question. As soon as it can be done easily and cost-effectively and has the support of payers and the FDA. Perhaps nanostring technology or other new techniques will accelerate the application. From a patient perspective, it is critical to understand what the major cause of disease is occurring, is driving these deleterious inflammatory and injury responses. Graft-reactive antibody constitutes a persistent inflammatory mechanism that has been difficult, if not impossible, to resolve, making it one of the key obstacles in preventing chronic graft injury. Omar, once we three agree that the goal is still to render a specific pathogenetic diagnosis from the various patterns and compositions of the inflammation we see in the graft. These will enable mechanistically targeted treatment. We also agree that we should pursue new therapies for further proof and for the benefit of the patient. As Paul Terasaki wrote in 2012, if removal of antibodies prevents chronic graft failure, final validation of the humoral theory can be achieved. So Omar says thanks to the debaters who provided many of the arguments quoted and the authors of the publications cited. I hope future ASHI Banff meetings will continue to provide insights into the diagnosis, mechanisms, and treatment of AMR and TCMR. Thank you. Galileo did not avoid the Inquisition, unfortunately. But perhaps I will. I know Fadi Lacus is in the audience. I'd be interested in his comments and anyone else's.
We've got time for some questions. Anybody like to go to the microphone? I'd like to introduce my co-chair, Dr. Lorraine Radisson.
There's Fadi.
Yes, hi. Bob, that was excellent, as always. I know that you have a focus on kidney, and of course kidney transplants are very common. But why do you think there is such a spectrum in terms of antibody-mediated injury, or even the appreciation of antibody-mediated rejection in different organs?
Well, there are some common features. I think the endothelium is the target in all organs. That's one thing that's common. I think DSAs themselves are common among all of them. Microvascular inflammation is common in all of them. But the criteria that pathologists use differ somewhat in the different organs. And I think there's less appreciation of the chronic, appreciation or identification of the chronic injury that can be mediated by antibodies that we see so clearly in the kidney. I think that's an area that will deserve more attention. Fadi, I hope you're unarmed.
No, you presented this in a very gentlemanly way and very eloquently, so I'm willing to surrender my case.
Well, we hope you will enjoy the conference.
So, however, I'd like to point out what irked me over time in this antibody-mediated rejection business, and what upset me is the lack of respect for the scientific method. In science, we don't look for things that support our hypothesis. We look for things that can refute it. That's how science advances. What I've noticed in the literature, but what I think you've corrected today, is that we find things that refute it and we just happily explain them away, rather than take them seriously and consider whether our initial hypothesis is wrong, or if there are other things that could explain the pathology.
Right.
And one good example is a mouse experiment where a mouse cannot make antibodies at all, but has B cells, and you can see full-blown lesions of chronic rejection. So my problem is not the hyperacute rejection, as you said, but attributing almost every pathology that we cannot explain to antibodies. And that's where my debate with the community started.
Thank you, Fadi. I think just to extend that point, we have a certain set of criteria we use as pathologists to make a diagnosis, and it's becoming clear as large studies are done and more specific techniques are applied, that there's a tremendous heterogeneity of these lesions and with significant clinical implications. And I think that's what we need to learn from. It's a little bit like you're looking at exceptions to your theory. And I think we will learn from DSA negative, C4D negative, et cetera, et cetera. And some of them probably aren't antibody-mediated rejection. I agree. Mark?
Thanks, Bob. That was great. With regard to our inability as pathologists to actually identify antibody in lesions of ABMR, even acute ABMR, it may be that our techniques are just not sensitive enough. I mean, there was a paper that just came out in the JASN about IgA nephropathy, and don't often see IgG in deposits of IgA nephropathy, and these IgG antibodies are presumed to be pathogenic in all cases of IgA nephropathy, and they've been able to elude IgG. But they found with confocal microscopy that they were actually able to identify IgG in all of these deposits in IgA nephropathy. So it may be that, we're just not looking with sensitive enough methodology to identify the DSA, not that the DSA are necessarily not there.
Right. That's a good point, Mark. And it may be a timing issue also. In vasculitis, you typically don't see the components after a few days in the vascular lesion. So timing may be also important.
Last question, sorry, just in the interest of time.
I'm an HLA person, not a pathologist. So my perspective is, we know not all HLA antibodies are equivalent. So in your experience, can you see which donor-specific antibodies really cause the rejection, either C4d positive or negative, in terms of class 1 antibodies or class 2 antibodies, multiple antibodies or single antibodies, high MFI or low MFI? Any insight?
Well, we know certain things are correlated with outcome. The complement-fixing antibodies, and of course those would include mostly IgG3, and the opposite, IgG4, is less associated with the dramatic changes, but more associated with chronic lesions. So I do think characterizing the antibodies, and there have been many, many studies on this topic, both the amount and the specificity, we know most of them are class 2 that are important, at least in the chronic setting, and their properties to either bind to FC receptors or to fix complement are probably also important.
Thank you. Thanks very much for an excellent overview.
I'll introduce our next speaker, who's going to be talking about exciting initiatives in DSA testing. Dr. Anat